A Wellesley College alumna, Dr. Pinn went on to attend the University of Virginia Medical School, the only woman and African American in her graduating class. She completed her postgraduate training in pathology at the Massachusetts General Hospital, during which time she also served as a teaching fellow at Harvard Medical School. She joined the faculty of Tufts University School of Medicine and also went on to become professor and chair of the Department of Pathology at Howard University College of Medicine. In 1991, she was appointed to be the first full-time director of the Office of Research on Women's Health at the NIH, playing an integral role in helping to define women's health as beyond women's reproductive health, and instituting numerous programs to increase career opportunities for women. A few of the many awards and honors that she has received include induction as a fellow into the American Academy of Arts and Sciences, the Elizabeth Blackwell Award from the American Medical Women's Association, as well as her ongoing appointment as Senior Scientist Emerita at the Fogarty Center at the NIH. Please join me in welcoming Dr. Vivian Pinn.
I'm not sure that your speakers should hear the critique of the day before speakers, because it makes you a little more nervous about what are you going to be saying about me tomorrow. So actually, I'd kind of like to hear that before I leave today so that I would know if I am invited back again, what would be better to do. And I have to mention one award that I got. This, I don't know how many of you know or recognize this. This is the Wellesley Achievement Award pin. This is what you get. And I don't wear it everywhere, but there are a few of us in Washington who have this pin, and when we see each other, we recognize it. But I don't wear it everywhere for fear I'll lose it, because this is very valuable to me. But Nan Overhauser was president when I got this, and I'm very proud of this award, although most people just think, oh, they say, what a cute pin, but it really has much more significance than that, so I wanted you to see that. So this is my first time joining the course here, and I should tell you also that actually Madeline Corbell and I were here at the same time in Severance Hall. She was a senior when I was a freshman, and I remember she was very impressive then, and I can remember we all wore those wool Bermuda shorts then, or whatever we called them, you know, those. And I can remember her walking down the hall by my door, because the freshmen, I don't know if you're still there, but freshmen in Severance were always on the hall, leading down to the front desk, and you'd see the seniors coming from the back walking by. But I can remember her from then, and it's interesting because that was the fall of 1958, and here we are in 2013, and I can still remember her. So she was walking the halls, so obviously she was very impressive even then. I don't remember everybody that was in my dorm in the senior class, or much less junior or sophomore class. So it's really been wonderful being in Washington, being able to watch our Wellesley alum and all that they do, and to just sit back and be proud of them. But as I thought about coming to address you, and I looked at the selectivity of this course, and I looked at your faculty, and I thought, oh my goodness, I can speak to a bunch of physicians and scientists anytime, but speaking to a group like this is a challenge. So what I want to do is to talk to you, because women's health, you know, I am a pathologist, and the kidney and was really my specialty, but that was over 20 years ago when I moved into the field of women's health, which was a new field. And I was trying to determine how can I put that in the context of what you're looking at in terms of international policies and international studies. So I hope what I've done is going to work, but if not, please tell me, because that way I'd rather hear it from you, so that if I get to do this again, I can do it a little differently. And I'm going to cover a lot, and I'll try to talk quickly so that I do have time for questions and discussion, and really comments at the end. But what I want to do is to sort of put into context where I'm coming from and what's happened with women's health here, because the U.S. has sort of led the way in making change, but no way are we just the leaders, because what we've seen is a big sea change globally in terms of attention to women's health. It varies from country to country, but in terms of following some of the kinds of things that we've done here, and that's what I have the most knowledge about. And then I want to end with a little bit on what is now becoming one of the main focuses on in terms of women's health internationally, and that is looking at the effects of urbanization. Many of the, at least from the standpoint of health, many of the international women's health organizations are really focusing on, and the leading biomedical scientific academies like the Institute of Medicine are now focusing on the effects of urbanization on women's health in the international community. So now let me see what I can, okay, this is going to do it. All right, so when I was here in college, and for many years afterwards, if you talked about women's health, people just assumed you were talking about having babies and maybe breast cancer, because women's health traditionally, in the medical world and in the world in general, women's health, and even today, I always ask questions of groups when I'm speaking to them about what do you consider to be women's health, and usually I'll hear pregnancy, I'll hear concerns related to the reproductive system, and I'll hear breast cancer. But one of the things that about 20, 25 years ago, people began to realize was that we really need to know more about women's health beyond the reproductive system, because we do have much more than just our reproductive system in terms of our health issues, in terms of our contributions to society. And looking at, with the coalition between advocacy and legislation and policymakers, questions were raised. How are medical decisions made in terms of how you treat women, how you diagnose their conditions? Are women used in that mix to determine what the standards of health are? And in fact, most research at that time, and I'm coming from the standpoint of having been involved in research now for over the past 20 years as a major focus, most research did not include women in those studies, and studies were done on conditions. If you had women in studies, they were usually related to just the reproductive system, but not looking at major conditions that affect women's health other than reproductive issues like heart disease and GI problems and pulmonary problems, etc. And so the question was raised, should not women be included in studies that would determine standards of practice, standards of insurance payments, standards of public health policy, rather than just assuming that studies with men would provide information that you could just apply to women as though they were little men in skirts, and that's sort of what the theory had been. So when I look back, I actually went to the NIH in 1991, about the time that this office was, I'm jumping ahead, let's just say when I went there to start this new office, it was interesting. When I'd go to talk about women's health, I'd have to start my talks with, what is women's health, to explain what women's health was and why it is important. Why is it important to even talk about quote-unquote women's health? And we've come a long way since, I think, where we were in 1990, 1991 in understanding that women's health means we're looking at lifespan issues, we're looking at the socio-cultural and environment in which women function, in which they live, in which they work, and we're looking at lifespan issues. We're not just looking at the reproductive functions of women, which is important not only in this country, but in terms of looking at the issues and problems facing women globally in terms of their health. So we have come a long way in terms of just seeing books written about women's health that talk about how to keep women young and sexually active and how to prevent menopause when women were saying that. This is true. There's a book written by Dr. Wilson published in 1966, which was the time that I was actually a senior in medical school, that describes women's health in terms of keeping women, keeping us sexually active, and how he could prevent the estrogen deficiency disease referred to as menopause. And as far as I know, estrogen deficiency, menopause is not a disease. It's part of our natural maturation process. And the only way that I know to prevent menopause is to die before you get there. So I don't know. I don't know what he was, but I didn't put those slides in since that wasn't really, but that's how women's health was viewed in the time that I was in medical school, and that was just sort of the general opinion. And remember, at that time, there were very few women who were in medicine, who were in the back rooms, and it was interesting. Sometimes the guys would forget I was there, and just to hear what they had to say about women as patients, etc. So we've come a long way since then, thank goodness. And just looking at now, looking at what are the major issues that affect women's health. So there we are. So I'm coming at this, and I really want to impress upon you the importance of research in making a difference. And of course, my research I'm going to be talking about is more that related to health issues, because that's what I'm speaking on, women's health. But obviously, research is important because, as you know, in an evidence-based world, if you want to make changes, it's not enough to just have anecdotes, and I could give you lots of anecdotes about many things, but that doesn't change public policy. It's data that makes a difference. And one of the important things we hear about, not only here in the U.S., but especially when we're dealing with women from around the globe and have meetings on these international issues, is that not every place is actually collecting the data to show these problems exist or the severity of the problems related to women, women's health, women in careers, regardless of what aspect you're looking at, and how important it is. And so this is one of my final messages. I'll give it to you first, is that if you really want to make a difference or really want to evaluate whether it's women's health, whether it's the progress of women in science careers, or if it's progress for women in other fields, you really need to have the data. And the data needs to be disaggregated in terms of looking at women versus men, and I don't mean in terms of competing with, but not just having data and saying women are part of this. If you really want to document how severe or how not severe a problem is, you really need the data. But to increase knowledge related to research for health applies to many other fields, that research is the major factor. Just think, I was a fully tenured, full professor, department chair when I left to go into government in a non-tenured position, and discovered when I got there I would accumulate 3 hours of vacation every pay period, and I'd left about 6 months of vacation behind in a government which I almost didn't go into because I thought I'd never survive in government because I like to say what I think, and I figured I wouldn't last long. So I'm still amazed I lasted 20 years, maybe because I did talk so much it got me through. But why would I do that when I was really enjoying what I was doing? It was because I had been fighting battles and being sort of outspoken over the years, looking at many issues, including women's health and how women were treated in the healthcare field. And I realized that research was what you needed, not anecdotes and not what you thought. And I thought this is a perfect opportunity to get in a position to make a difference. So obviously, I think that research is important. Why? Because it's the results of research that gives us the data, the facts that can lead to how we change, how we teach about our education, what ends up getting into textbooks, be they medical, scientific textbooks, or any other kind of textbooks, and that influence public policy. And in this case, I'm talking about health care. And it's the results of research that eventually lead us to change our own ways of handling our health, because we learn what is right to do and what's not right to do. How many things you hear about on TV, on all those medical talk shows during the day that are really, how do I put this? Because if you're a fan, well, you obviously are busy, so you're not watching those talk shows, but the late at night ones, and I look at things that are there and just go, my gosh, people are going to believe this because you've seen that commercial about it. I know it's true because I saw it on the internet, you know, that people believe this. But if we really want to get the truth out, we need to do research. We need to understand, make sure we're getting the facts. And that's how we change public health policy. That's how we change standards of health care. That's how we change how we address ourselves and conduct ourselves, either in our careers or in our personal lives. Well, back to what I ended up doing with this attention coming from the advocacy community, going through the congressional community. The Congressional Caucus on Women's Issues was very active at that time. Pat Schroeder and Olympia Snow from Maine were the two leaders of the Congressional Caucus on Women's Issues. They picked up this issue. They asked the federal government, what are you doing to make sure that we are giving attention to women's health? And this 1990 may seem like a long time ago to you, but to some of us that was just a few years ago. But just to think that all that time until 1990, the federal government in this country had not given any attention specifically to women's issues. And I'm not giving you the whole women's health spiel for this country, but there was a report in 1980 by the then Surgeon General, saying we really need to give more attention to getting data on women because there's very little data on women, and here we are 10 years later getting there. But in any case, this office was set up, and Bernadine Healy was looking for, she was the only woman to serve as the director of NIH, and I was attending a meeting actually representing the Fogarty International Center, and happened to be sitting with her when she invited me to come out and take over this new office. And that's essentially what I did do, because I thought, you know, all these years I've been spending my own time, you know, the evenings, the weekends, going out to address issues related to women's rights, women's health, the, you know, opportunities for women and minorities in fields of science and medicine, health and public policy. And now they're going to pay me to do it, so why not? It was the right time, and I was right. So here we are 22 years later, and it's been quite a time. But that's how I ended up going to do this. And this office was set up and actually was to ensure that women are included in studies related to their health issues on other than just reproductive studies, to make sure we're really learning about women by looking at women. And this covers everything from biomedical to psychosocial and socio-behavioral aspects of health, and that is important. So bringing it up to today, so I jump ahead to get to what I want to talk about more with you, since this is an international institute, is that as we have made changes and progress here, we've seen that in many countries around the world. The U.S., I'd like to think, because we are one of the few countries, and we were probably the first country, to really have a formal Office of Research on Women's Health and establish Office of Women's Health. This has really become a topic in many other countries around the world. And it's interesting because it's not just those with offices, but many countries where there's more attention being given to looking at disaggregating data, or getting the data, disaggregating it, and really giving good attention to what is the status of women in terms of their health and what are the factors that are contributing to their mortality and morbidity. And so this idea of looking at women's health across the lifespan, we like to think we've done much, but it is applicable, and we see this across the world. Two things about women's health important. One is that this idea of putting women in clinical studies really has led to not calling this so much women's health as the science of sex and gender, meaning we're looking at what are the differences in the biological characteristics between women and men, as well as what are the societal expectations of us being male or female, and how do those apply to health and health outcomes. And this is not unique to the United States, and it's been really important to see this going around the community. And just to give you an example, the first ever Congress on Gender Medicine, International Congress on Gender-Specific Medicine, or Gender Medicine, was held in Berlin back in 2006, and I had the honor of serving as the honorary president. But it really sort of put us in our place as we saw from the U.S. how much was being done in other countries, but then we also saw how many other countries needed to really be giving this more attention, because there was a great disparity between what's really understood in terms of what gender-based medicine, as some like to call it, is, or gender-based health care really means, and really those who get the message and are making a difference. The other, and that's just to point out that sex differences research, which really leads to gender issues in healthcare, which leads to giving attention and considering the importance of protecting women and their families and preserving their health and their right to good health, their access to health care, and what are the major factors in their environment that affect their health, as opposed to men, or could affect both, but to understand where there are differences to women and make sure that those are addressed. Now, one other thing, while there are lots of efforts to look at women's health around the world, remember the office was set up and this focus was established to make sure that women were included in clinical studies in the U.S. other than just reproductive studies. So that if you are going to do a study on heart disease, which we know is the leading cause of death for both men and women in this country, but most of the studies on heart disease up until the early 90s really were focused on men. Now, there's scientific reasons why they could get away with that, in that heart disease really begins to appear most often, most usually about 10 years after it does in men, and there was always concern about women's menstrual periods affecting the being a confounder in studies. But after all, that's part of our lives, and instead of being a confounder, it should have been considered a factor to study in that. But Congress said it's not enough to have an office directing this, and they actually passed a law in 1993 requiring that for federal funding, doesn't apply to industry, but for federal funding, and remember NIH is the primary funder of biomedical research for the federal government here, and they passed a law requiring that any research funded by the NIH that addresses a health issue that affects women or affects minority populations must include women and minorities, and not just stick a few women in and say we've got some women in there. Must include enough women so that when results are there, that an analysis can be done to determine whether or not there are differences between men and women in the results, or looking at the application of the intervention, whether it's a drug or whether it's a prevention, a technique, etc. Now and actually I presented this in many areas, and especially when I was the keynote speaker at the Men's International Health Meeting, speaking about what men can learn from women's health, that was held in Nice a few years ago. I realized, because we had members of Congress as well as members of the men's health community saying, now NIH is discriminating against men because you're only putting women and minorities in studies. So I have to add this to all of my slides. The assumption is the studies are going to include men. And so the law was designed to make sure that in addition to men, we're also including women in these studies. Now, I wanted to point this out to you because, one, we're the only country in the world that actually has a law that requires the inclusion. This is public policy, public law, that requires the inclusion of women and minorities in clinical studies funded by the federal government. But we've seen many other countries in many other areas that are putting this into effect, but can do it only in a limited way because it has not been passed as a law. But there's great interest, and many areas and many different areas of the world are beginning to look at this or to try to put it in place. But having a law that requires that means if you apply to NIH for funding, you have a grant, and you want to study, let's say you want to study heart disease and diabetics over the age of 40. If you don't have women in those studies, I can say you're not going to get funded. You're not going to get the money to do your studies because you don't have women in your group. So you're going to go back and you're going to put women in your group because you want the funding. Otherwise, you're not going to get funded. And that makes a difference where you can hold up funding in terms of getting requirements in place. For other agencies and for other countries that don't have the law, it's a little more difficult to be able to do that. But this is moving research design from exclusion, and without getting into all of this, and this could be another whole topic, looking at issues of protecting subjects in research, and this is something of importance not just in the U.S., but looking at the broader world, and has been topic of many discussions, but to that of inclusion for health reasons. The other major thing I want to focus on in terms of in general that is important, not just in the U.S., but globally looking at women's health, is what I see as an important factor for you in this institute, and that is something that some call multidisciplinary approaches. I like to refer to as interdisciplinary approaches, because by interdisciplinary, I'm thinking that you have different areas of wisdom you bring together to address many different issues. And if you're looking at health, you really need everything from urban planners, architects, those in engineering, those who are environmentalists, as well as those who are in medicine and nursing, social policy, civil service, the criminal justice system, all of those to work together to make a difference. And so the idea that interdisciplinary collaboration for whatever topic, to me, is, we're hearing more and more about it. We've sort of been doing it in other areas, but I think in terms of health, and especially world health, It's so important because just, you know, you can have a concept if you're in health or medicine, but to get it implemented, it needs to be part of public policy. It means you need those who are in legislation, those who are in government to help enact laws or policies to make sure that what we've learned gets enacted. We need those in the communication skills fields to get the message out so that individuals can learn what's important, what's helpful for them. And the word I'd like to use is synergy for interdisciplinary. I think of multidisciplinary as people coming together, bringing different areas of wisdom and expertise, but you're still sort of in your own silo, but together. And I think of, and maybe this is more semantic, but I think of interdisciplinary as coming together and bringing your wisdom, but merging those silos to work on a single problem or a single issue. And this is the other great lesson I think we've learned that's applicable in many ways. So I like this quote from Helen Keller, which is, and to me, this sort of gives the essence of interdisciplinary research, interdisciplinary healthcare, interdisciplinary approaches to whatever issues we're looking at, and that is by working together, we can do so much more, bringing that synergy, and that's important. Now, you'll see this is a little off, but that in addition to women's health, I also am able to now really address you a little bit better in terms of health in the international community and research, because as you heard, I have been given, how do I put this nicely? I was bestowed with the title of Senior Scientist Emerita at the Fogarty International Center. Now, Fogarty, at NIH, there are many different institutes. You've probably heard of the Heart, Lung, and Blood Institute, the National Cancer Institute. There is a Center for International Studies, and while different parts of the NIH may fund work related to the international health community, the Fogarty International Center is the major area, a major focus area of the NIH to focus on global health issues. And Dr. Glass, who is the director, has invited me to work with them. It's not a job as such, but it's an honorific title, but it allows me to be there to focus in, especially when there are issues related to women's health or inquiries from around the world related to research related to women's health or career development. So I thought this was very fitting, and when I told him I was invited here, that kind of, for this institute, this was just very, very fitting, and I hope that by this time next year we'll have many new programs in place related to women's health. And I really, without discussing what's actually on the slide, this was a reminder for me to say that NIH does fund research through the Fogarty and through other institutes in many countries of the world. And really, our money from the federal government goes out to help us study health issues, environmental issues around the world. Remember, we have a law that requires the inclusion of women and minorities in clinical studies if you're going to look to NIH for funding. And it is the major provider of biomedical research, and NIH funds researchers not only in this country, but researchers from around the world. We have run into a bit of a snag, and while I was at NIH, now that I'm no longer head of the office, somebody else has to deal with this. But it's been interesting and something to think about, because what is a minority in this country may not be considered a minority in another country. And while we are looking for the data to make sure that the research is being all-inclusive so that the results of the research can be applicable to all populations, we ran into, or some of the researchers and funders of researchers ran into some real problems with some of the studies that were being done in other countries. One, because they said people didn't want to be considered a minority. Well, you didn't have to tell them that. You asked them to classify where they are. The way we ended up dealing with, and then they claimed that in some countries it was considered an insult to ask people about their racial and ethnic heritage. And so one of the examples we were given was in Canada, it was against the law. Well, the person who used that as an excuse didn't know that I was good friends with the director of the Institute on Gender Studies in Canada, so I simply picked up the phone and called and found out, no, in fact, they were looking, they have different categories, because you've got the Aborigines and you've got the Indian populations in the northern provinces of Canada, but it was not against the law, just different classifications. I won't spend a lot of time on this, but it is an issue that continues to be debated and one to think about. The way we ended up handling it, because we have a law with Congress saying you need to tell us who's being included in clinical studies. So we asked our scientists to classify those that were in their studies, if they're from another country, as though they were Americans, because that's what the Office of Management and Budget here in the U.S. requires, that we have a classification system. You're either Hispanic or non-Hispanic, and then the racial groups coming underneath those two ethnicities. And so we have asked investigators to classify those that they study, how they would be classified if they were in America, but then we kept records of those that were domestic studies versus foreign studies, because sometimes what is a well-intentioned law is not as easy to implement when you go beyond the USA. And this is an issue that requires lots of discussion we haven't done. So let me just say a little bit about women's health, and I kept cutting back what I was going to say. So let's just take a look. I always like to compare women with men to show, for many years we just had overall life expectancy. And if you look at many charts, you just see life expectancy. You don't always see the breakdown. You have to search for breakdown between men and women. But it's interesting. Here, looking at the change in highest male life expectancy, Japan has remained at the top over the past 10 years, interestingly. And if you look at lowest male life expectancy, look at 2010, and we've gone from Angola to Haiti. And if you look, you can sort of assume that some of the things, some of the conflict we're hearing about, some of the other issues we're hearing about, or that we know about that are happening in the world, are affecting life expectancy, because this takes into account all the different areas. Look at for females. It's interesting. Japan continues to have the longest life expectancy for women, and there have been a number of studies talking about health issues. For example, the incidence of breast cancer is extremely low in Japan, but as Japanese women get assimilated into the Western country, as they come closer to or have been in the U.S., you see the rates of breast cancer going up, which sort of lends some theory of the environmental and changes in eating habits, et cetera, as contributing to breast cancer, and what that impact might be as we look at global health in general. But look at the lowest area of female health life expectancy, and Haiti has made it on, along with Afghanistan, which continues to be there, and it begins to show you the effects of not just of conflict, of tragedy, of war, of what's the word I want when have hurricanes and other things? What's the word I want? Thank you, disasters. The brain getting old. I'm blanking, but that's it. The effect that can have when you look at life expectancy a lot. And then looking at the burden of disease. This is not looking at cause of death, but looking at diseases, injuries, or risk factors that affect the health of women. I thought this was interesting, and I couldn't get this to be interactive because it's beautiful if you see it change. But look from 1990. This is for women, all ages, looking across the globally. So if you look, lower respiratory infections, and there's a major contributor to that. It's especially important for women and for young girls and kids in the house, and I'm going to come back to that in a minute. But look at how ischemic heart disease has risen up to be second in that terms of burden of disease. Stroke has gone up. We've seen a decline in diarrheal diseases because we've really seen a lot of public health efforts addressing diarrheal issues and infectious issues and nutrition issues, so that's beginning to go down. Malaria continues to be important, but HIV/AIDS has risen, and we know that that's a very important issue overall, but in terms of looking at the total global burden of disease, it hasn't gotten to the top yet. But I just thought that was interesting to see the shifts in the total burden of disease. But let's look at women's health. Women still live 6 to 8 years longer than men globally. In the U.S., that has been narrowing because women are smoking more, they're not taking care of themselves, and you're seeing an increase in heart disease, while men are stopping smoking more than women are, and their life expectancy is increasing while women's is stayed about the same, so that gap has narrowed from 7 years more for women to about 5 years. Looking around the world, we see that. And we can see that, and I've already shown you life expectancy in some countries much longer than we have in the U.S., from 80 to others, where 54, just imagine being 54, and that's the expectation for living, expected by those in the region. Sexual abuse, we know, is far more common for young girls or for women, and you know, just what's been in the news recently points out some of the really inherent issues. And I think looking at issues of rape and sexual abuse is important because at one time it was seen just as a criminal justice issue. And now we've at least accepted where I think it belongs, which is as a health issue, but one that we have to look at in terms of both the health arena as well as the criminal justice system, as well as social services, region, area of responsibility. But something we know from the current day news is extremely important. And of course we've seen, and I think one of the things that has contributed to an increase in life expectancy for women has been that we've seen an improvement in maternal care, but not to the point that we have eliminated in many countries still the dangers of early death from pregnancy and the complications of pregnancy. So let me just hit a few of these things. Looking at girls and infants and adolescents, what are some of the major points about health? This is looking globally, not at the U.S. specifically, but looking globally. Interesting, injuries from road traffic accidents, as we see various types of road congestion, depending on which parts of the world you're in. For adolescent girls, the potential for getting HIV/AIDS, again coming back to that rape and forced sexual activity on young girls or adolescents. And it's interesting because pregnancy-related complications are the leading cause of death among girls 15 to 18 in developing countries. And without getting into abortion rights, we know that in many of those areas, unskilled abortions and leads to complications and sepsis and death. And of course, substance abuse, not as much a problem as the others. Looking at reproductive health, looking at, you know, we talk overall about heart disease being the leading cause of death for women, not just in the U.S., but globally. But if you look at it by age, for women between the ages of 15 and 44, meaning during the reproductive years, HIV/AIDS globally is the leading cause of death and disease worldwide. And that gets back to unsafe sex, and we could have a whole long discussion about issues related to that. Maternal health, again, is a problem. We made a lot of progress, but we haven't gotten there. And cervical cancer, I'm going to want to talk about a little bit more, hopefully, if I haven't ad-libbed my way so much that I haven't gotten, because I want to talk to you about the vaccine. Violence, and violence ties into sexual abuse, but violence in general is important, and it is widespread around the world. And I'm sure you could tell me more from your other lectures or what you've had, but it is important. And the resulting depression and suicide is an issue of health and of public policy that we need to address. And actually this whole issue of pulmonary disease and cook stoves I'm coming back to in a second. And for older women, as we see women living longer, we do see that cardiovascular disease for older women is always typically thought of just like here in the U.S. And part of our attention here, the results of our attention here in the U.S. to looking at heart disease, cardiovascular disease in women is that we're seeing that attention worldwide and recognizing for our older population that in fact cardiovascular disease, that means heart attacks and strokes, leading cause of death. So looking at leading cause of death for women by looking at income groups of countries, if you look around the world, heart disease and stroke, cardiovascular disease, number 1, number 2, followed by lower respiratory infections. And I'm going to say a little bit about some major efforts to addressing those lower respiratory infections really in chronic obstructive pulmonary disease, which comes down to cook stoves. I'm sure if you've had discussions on cook stoves, it's a major topic that I'm going to take a few minutes to talk about in a second. But looking at low-income countries where women are more exposed to fumes from indoor air pollution and cooking and being within the homes, you see that in fact that respiratory problems are number 1. But then if you look at middle income and high income countries, it looks similar to to the U.S. in terms of heart disease and stroke. This country, I assume you know, heart disease is number 1, cancer is number 2, and number 3 is stroke for us. And that reflects our country, and then looking at these from around the world. Hypertension, looking at heart disease and ischemic heart disease, just for example, looking at risk factors leading to death, raised blood pressure, and we could talk a lot about that, but just to show you, looking at areas, so the darker the color, the more orange the color, the more prevalent the high blood pressure and the need for treatment, looking at men and looking at women. Not quite as bad, but still we see it there, but just a contributor. Cancer deaths, looking at the rise in cancer deaths. World total, we can see an increase in cancer deaths around the world. This is for women and men. But I thought it was interesting to look at high-income countries where there's more access to health care, there's better care, better treatment, better access, and better personal care. The deaths have remained about the same, while in low and middle-income countries, we see a great increase over the past, and the projections for coming up for deaths from cancer. So overall, cancer, obviously breast cancer, just as in this country, is the most common cancer. Colorectal cancer is the 3rd leading cancer for women in the U.S. But the cervical cancer, looking worldwide, cervical cancer is not that common in the U.S., but any death from a cervical cancer is a death that should not have occurred, ever, because it's easily detected and should be able to be cured, but we do see some death. If you look worldwide, the fact that cervical cancer is the 3rd most common cancer, it's important, and so if I get through some of this, I can come back. So look at breast cancer. It says the 2nd most common cancer, that's looking at cancers for women and men, but it's the most common cancer in women. And if you look at the rates for breast cancer, and looking at different countries around the world, it's interesting to see Belgium, Denmark, France, the Netherlands, Israel, Iceland, Ireland, Uruguay, Switzerland, New Zealand, and coming down are those with the highest rates of breast cancer. Kind of interesting to see that the U.S. rates 19. But there's a lot of research going on here and in other countries, and Dr. Fumi Olapati, who's in Chicago, is well known. She's originally from Africa and has been doing a lot of work on studies, very genetic studies, looking at triple-negative breast cancer, which you know is the type of breast cancer, if you want to get one, that's not what you want to get because it doesn't respond to hormonal therapy. It has the worst outcome, progresses most quickly, although we have saved some women with that because I don't like to nil hope. But looking at what causes it, is it a different type of cancer? Is it genetically determined? And she's been doing research on triple-negative breast cancer, and for example, looking at different populations, different parts of the world, looking at how triple-negative is very common in African women. Is that why we see it being seemingly more common in African-American women in this country? And I wish I had time to talk to you about some more related to breast cancer. I happened to have been in Egypt at the time. I know how many of you remember a couple of years ago, the pyramids were turned pink because there was a march for breast cancer in Egypt, bringing many women from countries there and looking at how many women in areas like Egypt and similar areas would not reveal they had breast cancer because they were concerned that their husbands or their loved ones would not want them if they had surgery on the breast or thought they had an abnormality in their breast. So they would go and just keep covered up and would not expose their breast cancers. And we were losing women, not just in Egypt, but in several other countries. But we took working with the Komen Foundation and with the breast, there is a breast organization on breast science. We went to Egypt, and we weren't sure we'd get any women to turn out because women didn't want to reveal they had breast cancer, and how many men would support that. And I remember some of the women there being very proud because their sons or their husbands showed up. And of course, looking at breast cancer, part of it is understanding the biology, but part of it, which we have dealt with in the U.S., don't think that's unique to Egypt or other places, but I think we've come a little beyond that here in the U.S. because women started talking about having breast cancer, then men started talking about having prostate cancer, and finally somebody realized it's all right to talk about having cancer because that way it's open and you can provide hope. But there's still lots to be done in terms of breast cancer, getting that openness and women feeling comfortable going for diagnosis or treatment. Lung cancer, most common cancer, and unfortunately cancer, lung cancer is the leading cause of cancer death in the U.S., as you know. Not as common, but for women, kills more women than breast cancer because it's more deadly. But cervical cancer, the third most common cancer in the world. Over 500,000 cases in 2008, and this is some of the most recent data, but it's about the same as it continues. And looking at the countries with the highest incidence of cervical cancer, starting with Guinea and Zambia, Comoros, Tanzania, U.S. is not on that because it's not as common. But what do we know about cervical cancer? What do we know about it? About 99% of cervical cancer is related to what? HPV. You know that, yes, HPV. And so what have we seen developed in the last few years that might offer hope? And why is that vaccine important? Has there ever been a vaccine to prevent a transmission of a sexually transmitted disease before? It's the first. Has there ever been a vaccine that can potentially prevent the development of a cancer ever in the history of the world? No. And I can talk about this vaccine not in terms of industry and the commercial side, but because the science for the development of this vaccine was done at the NIH by 2 investigators and their colleagues at the National Cancer Institute. And I was at NIH then when they were ready to go to clinical trials, and so our office actually funded the first clinical trials to show that this was an effective vaccine, which gives me the right to get the data as soon as it's available, but also allows me to really keep up with what's going on. But I thought when they were doing this work, and if I run out of time, just tell me when I'm about 15 minutes out of time, and I'll stop talking so I have time for them to ask me questions. But I remember when they came to me and said, now NCI had a huge budget. It's one of the best funded institutes at the NIH. In our poor little office, I mean, by comparison, we didn't have a lot of money. But this vaccine, in its basic laboratory work, had advanced or seemed as though it was working in the laboratory faster than they had expected. And they wanted to put it in clinical trials. And so when they came to me to talk about it, I thought, this could be some of the most exciting research for women's health ever, because cervical cancer deaths shouldn't occur at all. And if there does get to be a vaccine that can prevent transmission of a sexually transmitted disease, that can prevent the development of a cancer, that's world-shaking. I mean, that's earth-shaking. That's amazing. And so our office put the first money in, and we've continued to fund. And now that I'm no longer there, I shouldn't say we, but that office has continued to fund the development of the vaccine. And I got some, and so I'm going to come back to that in a minute, but quickly. So I've learned a lot, and I have the opportunity to look at sort of global health from working with the Fogarty Institute. But global health or international health is important for the NIH, which holds for the administration. I'm not speaking for the administration, but what happens or what's a priority for the administration and Congress really helps us with our funding, because all the funding for NIH is congressionally appropriated. And that means they provide the funds. So it's good to have them on our side. And if they're not, sometimes like when we wanted to do the sex survey of teenagers, because if you're going to try to prevent sexually transmitted diseases in teenagers, adolescents, you need to know what their habits are, who influences them. And there, believe it or not, there was a time when, back in the early 90s, when we had funded what was called the Teenage Sex Survey, not to learn about sex, but if you're going to do prevention and you're going to deal with health issues, you need the data. Who influences, who helps kids determine, not kids, young people, determine what their habits are going to be. And some member of Congress got wind of this and made a big deal out of it and pulled the funding, and actually had language in the law saying that NIH could not fund any teenage sex surveys. So don't quote me on this. He's gone now, but you know, this was a few years ago. We felt it was important. AIDS was beginning to rise. We needed to know about the transmission of AIDS. Other sexually other sexually transmitted disease. I haven't had my coffee. That's all right. Thank you. and just important from health, and looking at suicide, looking at self-confidence, looking at so many related things. So it just so happened that a few years later we got an application to fund an adolescent health study, and sex wasn't in the title. And that study happened to come in from about the same institutions that were going to do the other one. But this was all about adolescent health. So if they had a few questions related to things we needed to know, that was fine. And so we funded that. And a few years later, the congressman who had made such a big to-do started raising questions. And we could say, you know, this is privileged information because it's confidential. It's related to an ongoing grant. We got wonderful information out of that. So you learn about ways in government. Since I'm not really in government, they're not paying me a salary, I can tell you some of the things we sometimes have to do. But it's important to have them on your side. Dr. Collins, who is the director of NIH, has been all over the world. And I'm pleased because there have been times when we have seen, if you want to know the truth, there have been times when Congress has said, we have limited funds. Why are we putting money in other countries? Why aren't we spending our research dollars in the U.S.? But obviously, we can't separate ourselves from the rest of the world, and we think scientific issues ought to be judged on the basis of science. And fortunately, with the Fogarty Institute and the Fogarty Center and the fact that Dr. Collins, who is the director of NIH, he's the one who discovered the human genome, as you may or may not know, all feel that it's important. And looking at global health in general, it's important, just as we're learning here, but globally, including here, it's important to start early. We get young kids to get good, healthy habits. By the time they get to be postmenopausal and dealing with some of those hormone issues, they won't need them because their health will be in good shape because they've developed health early. But that isn't always possible if you're dealing with poverty, if you're dealing with urban areas, you're dealing with some of the other issues I'll get to in a second. So it's important to pay attention to the environment. The interdisciplinary collaborations I've mentioned about, and recognizing that for us in the U.S., to talk about global issues not as their issues, but they're all our issues. They just may appear in different ways, in different forms, or to different degrees. So let me now just say, one of the things we talk about is implementation science being important, especially in the global community, just as it is here. You hear in the biomedical community here, they're always talking about translational research, meaning you do research, you get information, you get data. How do you apply it to the bedside? They call it bench to the bedside. But a lot of what we do in terms of research and data is really translation into community programs, translation into public health policy. And that also is referred to as implementation science. How do we take what we have learned from research and really make it work in the community? And this is extremely important as we look at the global community, the international health. And this is a little house that has part of the Fogarty Institute. Actually, I'm in the building right across from that, but where we're developing, taking science and how we can apply it to policy and programs. And also a number of international scholars come and spend time at the Fogarty on learning. So just an example of looking at world's health, HIV/AIDS. I remember in 1990, we still had AIDS babies, HIV babies, not just in the U.S., not just around the world, but here in the U.S. And it was in the early 90s that the first research studies came out showing that we could prevent transmission of HIV to infants born of mothers who had AIDS. Now you pretty much accept that you don't have to have that transmission. But at one time, it wasn't so cut and dry. And if we can't get the vaccines and the treatments into parts of the world, especially underdeveloped countries, where there is HIV/AIDS, and we can't get the medications there, or can't get them there in affordable doses or affordable government programs, then we're still going to have high rates of transmission. So here's another area where what we've learned from science needs to be part of that implementation program. And this is a program that the Fogarty and the NIH sponsored. Again, it's still because we still have a problem looking at taking what we know and how to implement it in other areas of the world. And has a program, the AIDS International Training and Research Program, where investigators and scientists go out to other parts of the world, or scientists or healthcare providers from other parts of the world come into the NIH and Bethesda to learn about what can be done and to discuss some of these issues. And because of time, just say that some of the programs and issues that have been addressed by these trainees in this AIDS International Training and Research Program are looking at treatment as prevention, and I think you understand that. The whole issue of circumcision, this is when we're getting into men, the importance, because there appears to be less transmission of HIV if the men are circumcised. And I don't know how many of you have seen in the paper, even here, women saying, I'm not going to have, or men saying, I'm not going to have my son circumcised. So you get into cultural barriers and the conflict between culture and what science shows us, and I'll leave that for a discussion somewhere else. Cervical cancer, you know, when women who are HIV infected seem to be more at risk for the HPV virus. Tuberculosis is so often a comorbid condition in women who are there, and looking at following through. So we have a research training program really to look at how to get the message out and what to do. And this is actually training people to carry it out, because it's not so much just the science as how do we get countries, how do we, not that we get, because we aren't the give all to end all, but how can we assist other countries in developing their workers to be prepared and able to assist, especially where they've got low capital. Now, I don't know how many of you read the Smithsonian. You're probably reading many other things, but I like the Smithsonian magazine. And it was interesting because I was looking through the Smithsonian, and sure enough, there was an article in there, this was just a couple of months ago, on smoke alarm on cook stoves. How many of you have heard about the issues of cook stoves? Good, so maybe you can tell me more about cook stoves. But when they first started bringing up cook stove initiatives a few years ago, I'm like, what are they asking for money for cook stoves for? You know, what is this about? It has become a major effort in an area of major importance. State Department is interested. The NIH has been interested. The Fogarty has sort of taken a lead for the NIH. The Office of Research on Women's Health has been involved, because what we've seen is that because of indoor air pollution, and I looked at this, talked about this before, looking at lower respiratory infection, a lot of that's related to indoor air pollution, and a lot of that's related to cook stoves or the environment for women cooking within the house with their children around them, and the importance there, and for eventually developing chronic obstructive pulmonary disease in more adults, in older women, which you saw was one of the major risk factors for older women. And the Smithsonian actually had an article on cook stoves, which I thought was really great. And we've seen, and we've been working on this within the federal government, but especially from the health standpoint. Look at this data. Indoor air pollution because of the use of solid fuels and how important it is. Look at that picture down there with the little kid there and the woman, just that environment from cooking within the house. And that we see all over. And the fact that almost 1 million children under the age of 5 have acute lower respiratory infections related to this, and look at the adult figures. Now, these are some pictures from that have been taken from areas where they're addressing the cook stove issue. And to me, it's just fascinating how this is like a few years ago when it was digging the wells for water. You know, that seems simple, a well for water, but what a difference it can make for health. And then here we are with cook stoves, and this just shows some members of the federal government and the scientific community, and I think Catherine Sebelius is in one of these somewhere. She's not in this one, but here's a cook stove that was used to given in one area to replace what was there. Here we are again looking at cook stoves and the whole issue of indoor air pollution. And here are some examples of the cook stoves that are taken. This is implementing. Science learned. There are problems. Research showed us that indoor air pollution was causing many health problems. What do you do with it? So you write it up and you put it in a book and you publish it, you got it on your CV? No. We need to know how to implement change, bring about change because of what we know. And this is an area, I mean, just look, I don't know much about cook stoves. I'm not even good with my barbecue in my backyard. But just think, designing something like this that's not expensive, and what a difference that can make for health. So cervical cancer, and then I think I can shut down unless with my time because I'm about up. But I have to mention this because I told you we were involved helping to fund this. Cervical cancer worldwide. We should not have 200,000 deaths from cervical cancer around the world. We should not have any here in the U.S. And we should not have these cases. You know what the origin is. Doug Lowy, who is the one who really discovered this vaccine or developed this vaccine, gave me these slides from a talk he just did. And if you look at viruses that are or infectious agents related to cancers, you know that H. pylori, which leads to ulcers, we used to think it was from stress and too much acid, but now we know it's H. pylori, HPV vaccine, and then other vaccines. And then you look at the worldwide incidence of HPV-associated human papillomavirus-associated cancers, and you see almost 100% of cervical cancers are related to HPV, 99.678, wherever you want to put it. But also anal, and we're hearing more and more about anal cancers, and most of them are related to transmission from sexual intercourse, well, from sexual transmission from anal intercourse is what I guess I'm trying to say. And looking, and rarely for the penis. We don't see many cancers of the penis, but we're beginning to see those, and they're mostly related to HPV vaccine. There are a number of studies around the world, but what I wanted to point out was that we're looking at how to get this out, how to make it more available. There have been studies showing, you know, it's a three-shot vaccine. We're recognizing that we need to have that. If you get one vaccine shot, will it be as effective? Well, they've shown that at least for 2, because so few girls are really getting the whole series of 3, it may be effective. Now tests are being done to see how long that will be the case. But we still have a lot of unanswered questions, which I can't discuss, but this was the major point I wanted to point out. As we're looking at public health policy, we're looking at science. I, for years, touted the development of this vaccine, thinking, this is great. Well, what did it do? It got me on the list of the anti-vaccine group. So I've gotten emails from all around the world, some nasty ones, not as bad as those I got from some of the animal rights groups, because there was a recommendation we need to develop female animal models. But for the vaccine group, I get emails, and now that I still get them on my NIH email address, attacking, because some really don't believe in the vaccine, but you know we can also get into discussion about those that don't want to take the flu shot or who think vaccinations have caused autism and how people really get influenced by this and the role of the media. Those are some interesting things to discuss, and they go all over. But since we're talking internationally, I can tell you I have gotten many international emails from all around the world for supporting this. But when the vaccine was developed, we as scientists and public health people were so excited. I don't think we really anticipated the backlash it was going to get, or the fact that the socio-political environment was going to really detract from the science of this. Because look who got involved. It was even mentioned in the presidential campaign. Like, you know, governors, I'm going to require this. No, I'm not going to require this. Teachers saying, why are you telling me my daughter must have it? Should my daughter have it? Should the schools decide? Should the parents decide? And while this is all valuable discussion, I think it really taught the scientific and health policy community a valuable lesson that we can't just see the science and the outcomes of science, but we have to really think more about the implications of the science and that sort of implementation science or translation to clinical practice, because I still think, and I stand by this being one of the most valuable findings with global implications, because you see that cervical cancer is common around the world, but at the same time recognizing we have to really not be an entity to ourselves, but think about all of the further implications. I had some other wonderful things to talk about, but I think I ad-libbed too much at the beginning, so I'm going to stop. Is our other speaker here? She's coming, but at least I'll stop so you won't be saying I didn't give you a chance to ask a question. I didn't really. I'm over, so until she comes, let me stop there. I was going to talk about capacity building. It's important to build capacity, and we have programs there, but that's sort of my take. So now you can tell me what you're going to say about my presentation tomorrow. Yes, I saw your hand first. Do that. We'll make them quick, and I'll give quick responses while we're waiting. Yes, here.
Hi, thank you so much for coming to speak. Just reading about your personal story at Wellesley was very inspiring for me, and I could personally relate to you taking care of a family member while you were here, and I just think that it's
You all
really...
got all that info, huh?
Yeah, sorry to read up on you, but
Yeah.
I just think it's being a woman of color and going to college here was just something that I could really relate to, so I just thank you again for coming today.
Thank you. I can remember that. I drove up. My mother was in Sloan Kettering, and because they had misdiagnosed her tumor, and she was in Sloan Kettering, and I remember driving up. My aunt came with me and pulling on campus in our green and white Chevrolet, what was it, Chevrolet or something, in that green and white car, and seeing Miss Frisch, who was the dean of the college then, and asking her, could I take a leave because I wanted to be with my mother.
Yeah.
And you know, when I went on to be dean of students, you know, I was dean of student affairs at Tufts and department chair. I've seen those who felt if you're going into medicine or science, you know, you shouldn't let family issues interrupt what you're doing, and who really take the hard line, or when they're looking at pre-med applicants who say, well, you took time out and you can't deal with pressure and stress. But I was always there to take the other side and argue, because I would never I would never take back that time I spent. I took care of my mother. She died on the 1st of February, and funeral was on the 4th of February, and I came back to Wellesley. I think I left on the 6th of February. Somebody helped me get the thank you notes out to get back for second semester, which probably worked well. I had really supportive roommates and classmates. But I'll never forget that Dean Frisch was supportive, and they really allowed me to have that time, and I've tried to carry it forward with recognizing that family is important. Career and education is important. I think it's important to get back, and that we have to recognize that we do have sometimes responsibilities for families. So I think I've helped a number of kids later. I have to stop saying kids, but when you get my age, everybody's a kid. So don't take it personally. Don't take it as a compliment. You know, somebody told me, I was coming through the airport and the TSP guy said to me, how are you today, young lady? I said, better, because you call me young. So, you know, you just get to go with that. But thank you for that. And I do hope that my experience and the fact that Wellesley was so understanding and allowing me to take the time off, that I've been able to pay it back by helping others. The other thing I'll tell you about that is being pre-med. I never got to take art history. I never got to take crew or music 101, because I always had science courses every semester, first thing in the morning, and I never got to do crew, art history, or music history, because I always started first semester in the fall, and I never could. I was always sitting in a lab somewhere. But having taken first semester off, because I took so many science courses and so many chemistry, and I was a SO major, coming back in the middle of the year, I couldn't get in all of those, so I took more chemistry and so. But I had to fill in my schedule, and I remember taking Greek mythology. David Ferris was here then. I don't know if he's still here, but I got to take his American poetry class. I got to take classes that as a science pre-med major I never would have taken. It was wonderful, not only because of my state of mind, but it led me also as a pre-med advisor and as a dean of students to always include in my lectures to pre-med students, remember, you're going to be in science and studying science the rest of your lives. But if you don't use your college years to learn out about life and living and things other than science, it's going to be very difficult to do it later. So I like to take my life lessons, and not all the biochem professors liked my saying that, but I made it through and I did all right. So, and I'm just better off for having studied Greek mythology and poetry, which I never would have. Anyway, question, I said I'd be brief, yes. You, and then I'll come to you, and then I saw here and then there, yes.
Oh yeah, I actually had a question, but...
Okay, let's move on so we can get to the others.
Yeah.
Okay. Thank you so much, Dr. Pinn. So I actually spent some time in South Africa working with the HIV AIDS retroviral treatment program. And I had a question about the mother-to-child transmission. You had talked about how in Congress here sometimes they think that focusing on global health and the NIH is not as important as focusing on domestic health. And I was just wondering, do you look at lower cost initiatives for some of these programs that exist here but are harder to implement in countries like South Africa?
Well, fortunately for me, we developed the science at NIH, and there are other parts of the government that look at costs. I think some of the research that we fund is to look for better ways, less expensive ways of delivery of interventions. But that was not a major responsibility. We want the best science, then leave it up to someone else to help figure out how to better do it. And very often, as you know, from looking at many of the medications that are on the market, if you go to other countries, they're getting them for pennies for what we pay on the dollars for here. So that gets into some of the industry kind of discussions and whatever. But fortunately, I was not involved so much in that except to help fund, like looking at the HPV vaccine, and that has a cost here. If we can just use this as one example, but since I was on it, if we can show that you can get prolonged protection with less than 3, that helps cut back on the costs in other countries, developing countries where it's needed. But that would be the way we'd approach it for research, from the research point of view from NIH. There are other agencies that are looking at that. You know, and it gets down to a real discussion of not just for HIV/AIDS, for other things, and the whole healthcare thing. You know, what is the value of the cost of life? I can remember way back 20, 25 years ago when I first heard that there were some in Congress who wanted to limit dialysis and no kidney dialysis for anyone over 55 because they were too old. And I was thinking, my gosh, you know, one day I may be 55. Are they going to just give up on me when I get to 55? Now we're looking in, you know, but it was like this was seen as a way to cut costs. So you cut off who's eligible for some of the life-saving treatments because you think after 55, you're too old, you know, you can just go on. Now we see people living longer, and we see people in their 70s getting transplants, which before were limited to really younger people. But there is a cost associated. So who makes the decision of who pays for it if you can't pay for it? Should you, if you have the money and you need a heart transplant and you have the money and you're just as sick but you're poor and you can't pay for it, should she be the only one who gets this life-saving technique? Should both be denied because both can't get it? Or should she also have access? And the humanitarian in me says you should not be denied the right to better health and longer life because you are from a state of poverty. And that's why there's no economist in me, because I don't have to deal with the result. I can say let somebody else deal. But it's a real problem because then I have to pay the taxes that's going to help to do it. So you look at other countries. So that's a long answer, but it's sort of saying, I recognize what you're saying. It's extremely important, and it's something that has to be dealt with at national government levels, at industry levels, especially when we're talking about pharmaceuticals, et cetera. But it's extremely important because I'd like to think that, but everybody's not going to get everything. Where do you draw the line? But on the other hand, I hate to think of folks who are denied and those who get an overabundance, far more than they probably need or deserve, because they have the money and they can pay for whatever they want. That's more than you asked, so.
Thank you.
Yeah. And then quickly, I will try to be briefer. I get carried away. You know, I really get passionate about this, so.
My question is relating to COPD. And the charts that you showed us, COPD incidences were higher in middle-income countries than in lower-income countries. And I wondered whether there was something other than just cook stoves by themselves that were driving COPD
Smoking?
Cases.
Smoking. Smoking is, especially if you look in the U.S., most of the people you see walking around with the nasal oxygen, because of, I don't know if you realize when you see folks rolling those oxygen things with the nose, most of them have chronic obstructive pulmonary disease because of smoking. So smoking is a major contributor, probably more in some areas. If you look at, and that's also a contributor in tobacco use, even and less refined tobacco, if you will, in some of the lesser developed countries. So it's not just cook stoves, but it's thought that respiratory infections early on for children when they're exposed to that damages their lungs and helps to increase the rates that we see as they get older. And that's, you know, a cause separate from just the smoking or whatever, and especially for those that don't smoke. But those are the major contributors, indoor air pollution, and then if you get into better developed countries or more developed countries, it really is most often related to smoking. Okay, over here, yes.
First of all, Dr. Pinn, I loved your talk. Thank you so much for being here today.
Thank you.
Now, I know in this room we have some aspiring architects and urban planners, including myself. So I was wondering if you could expand further on how architects and planners can include women's health in dialogue and in city design.
Yeah, I think, things like keeping in mind access, streets, let me see, how can I put this? When we're looking at interventions for health, we're looking at design of cities, looking at where people live and how they're related to the rest of the community. I'm not sure I'm voicing this very well because I'm always pushing the interdisciplinary concept and saying how important it is. But keeping in mind sex differences. How often do you think about sex differences in terms of, and about disability access when you're designing buildings, when you're designing, this is a straight down and dirty example, but just to show you. I remember when the Denver airport first opened, that was a big structure. Everybody was talking about this big fancy airport in Denver. And I had to go to the ladies' room because I was changing planes at a long. There were men's rooms everywhere. I had to walk forever to find a ladies' room, and there was a line out the door. Okay, that's just a very simple thing, but and everybody was saying, whoever designed this airport didn't design it right, because it's like being at a football game. The lines are always out the door for the ladies' room, and the guys are walking through and out. Not always. I heard somebody talk about staying in line. So it's a matter of understanding that in designing structures, in designing cities, in designing roads, in designing buildings, that there may be sex differences in terms of access, in terms of needs, accessibility, not just for healthcare, but just for everyday tasks. And you'd be surprised things you think about, looking at how steps are designed. Now, I had a leg paralysis because actually I had a bone cancer, same one that killed my mother. I had 31 years later, but fortunately I was saved. They found it. And I've become I think until you live that way, I've become very interested in and very well aware of the limitations of most areas for those who are physically challenged. And you just wonder, who designed that set of steps? It looks beautiful. But if you are disabled, you never get up and down. Looking at the sidewalks and the curbs, keeping in mind health issues. I think a lot of this is covered so well today because people are much more aware of the need for solar energy, for the environmental changes. But just providing, since we know that physical health is important, physical fitness, in designing a community, designing a building, to make sure you have built into that design room so there is space for building in physical fitness activities, something you didn't think about before. You want to make sure you got a minute desk in there as you're good and cut back on extra space. But today our lifestyles are changing, I think, for the better. And so making sure you've got a park area if you're designing apartment complex or living complex. Remember, you're going to have children, and it needs to be safe, but also you're going to have adults, and adults who are taking care of children watching, or the parents, but who want to be in a community where they have access to. I could ramble on, and I don't have all the ideas, but hopefully that gives you some idea. And if you need to think about it, just remember sex differences and just think about the Denver airport, and then it will remind you of some things to think about. Yes?
One more question.
Okay, and then...
Well, first of all, thank you. And it's really on the shoulders of you and other alumni that all of us stand and are able to be here today. So thank you for that.
Thank you. I'm standing on all those others who came before me and gave me a boost and helped push me through, because I can tell you there was many a night when I think, I'll never get through this. Will I ever make it out of here? And this was before the computer. I can't, when I was in high school, my mother made me take she told me, you're not going to sit in study hall, because with a study hall you like is you could gossip and you could talk and you could pass notes. And my mother said I was not going to be allowed. And she made me take a typing course. I'm like, I'm pre-med. Why do I have to take a typing course? Mm. And I got to Wellesley, and I thanked her for having me take that typing course. Because I can't tell you how many papers. That was before the computers. You all would not know about this. You might not. But, you know, you go to the library and you take all your notes on index cards, and the paper's due 8 o'clock the next morning, so you come back and you put, I shouldn't be telling you this, but spread those index cards around you on the floor, and you get your typewriter, and you sort those cards, and there's no, I mean, these were really carbon copies days. You used carbon paper, and you erased if you made a mistake in those cards to type those papers and turn it in, and people who had to pay somebody to type their papers were in trouble because they went with what you gave them, at least if you did it yourself, and you had to get it to them a few days in advance. But anyway, how did I get off of that? I don't know. Anyway, well, things have changed, but thank you. Okay.
And, well, so my question relates to something that sort of came up throughout your talk, which is the politicization of often women's health care, particularly surrounding things like vaccines and the ways that those can, vaccines and things like cancer, issues that we can all agree that we're trying to combat. But we saw even in the recent election year the ways in which questions were raised about organizations who fight cancer, the Susan G. Komen Foundation that you brought up, Planned Parenthood. And what is your take as someone who's been on the policy and scientific end of things in assuring health as public health, women's health being a part of public health, while also addressing these concepts that still seem to be very sensitive in our national
How do we keep objectivity in science when we live in an environment where politics appears to rule, especially if politics controls the dollars? And one of the things I can tell you, when I went to head up the office, there were many who said, and one of my biggest battles was, there were many who said, especially men, because women were so happy there finally was an office to look at their health. And actually I was getting calls from women and from men wanting to know about issues related to their daughters or their wives or their mothers. So there was a lot of joy about it. But most of the grumbling came from male scientists who said, this office is just a waste of money. It's going to be putting dollars that are just going to be wasted when it could go to the kind of research I'm doing that's real research. And my response was, and what I spent most of the first years in that office doing, was saying we are a scientific programmatic office. And while the concept may have arisen out of the idea related to being politically correct, we're really not trying to be politically correct. We just want to make sure that there is equity in science and knowledge related to males and females, and that I can assure you that every project and initiative of this office will be science-driven. And that word, science-driven initiatives, were what carried us through. Every bit of research we funded, every program we put in place was reviewed just like anyone else. Or any other project. It was always based on a scientific premise with a theory. Nothing that came in because my grandma said we should do this and we want to do that, or I think we should look at women. It had to be based on, we have seen in this environment that women seem to be more susceptible to this than men, or we've seen that women have lupus more than men. How does it affect men, and what's the difference? Or if you have someone who's addicted, do you use the same techniques to overcome that addiction in women that you use in men, or should there be differences? So that we made sure that we could say there was a scientific basis for what we did. And I had to stand very strong on that because we knew we would, but it just, for those who felt this would give them a way to, we're wasting that money after their research was so important. It was just going to be looking at men. They didn't really need to be looking at women. After all, there are no differences. And I can remember, being told, you're not going to find any differences between women and men. Well, that's not true. And part of it is to document when studies are done. And there may not be differences. There are some medications, there are some interventions for which it's been shown that men and women respond the same. That's important to know for your knowing what you should take, for your doctors knowing what they prescribe, for your nurse practitioner knowing what to do. But on the other hand, we're also finding great differences. Some medications work better, work differently in women than men. Did you just see, I mean, it was in the news, wasn't it, last week, that Ambien, that there needs to be a difference in the dosage administered to women for Ambien because it has a stronger effect. Women seem to metabolize Ambien differently than men. Well, hell, I could have told them that 5 years ago. I mean, we know that. But all of a sudden, somebody finds out because probably somebody had a reaction. But I could have told them that because we've been preaching for 20 years, you know, that women metabolize medicines differently than men, and that due to differences in body size, somewhat due to hormones, somewhat due to the effects of our hormones on our liver function, and some other factors maybe we don't know, but weight and size, structure, organs. So that should have been a given. But if you look at the black box and look at what's on medications, I used to clip them out, I think the drug companies, and show them in my talks. I think they got smart, so you don't see it as often. But you look, and even the ads in the magazines, and you'd see, you know, use this medication, it's wonderful, it'll cure you. And then there's a little line that says this medication has not been tested in pregnant women. And my response was, you know, women don't go, or women of reproductive years. And you realize, to be in a clinical trial years ago, you had to promise as a woman that you would not get pregnant, and you either had to have your tubes tied. I didn't, this was before I came in the picture, but this is what I would do. You either had to have your tubes tied, or you had to well, make sure that you were not going to get pregnant, because they were so concerned about liability if you were taking an experimental drug and your fetus got affected. So that was one of the contributors to women not being in. So I think I kind of got off the topic a bit, but it's important. But I think what is important for each of us to do, I do it in my private life as well as professional life, is to be aware of what's important. Follow what the people who are making decisions are saying. I've seen many a politician back off their stances because they want the votes, and the votes are what put them there. And if they think the votes are not going to be with them, there's some rare ones who say, even though my district wasn't in favor of this, I feel, or was in favor of this, I feel in my heart that I have to go with what I think. And they usually aren't around to go with their heart with what they think after the next election, because people want representatives who are going to represent them. So you have to pay attention and be vocal and be active. You need to support those who are doing what you think are following the right, following science, not trying to influence, who can follow their heart, their religions, their thoughts, but are not imposing on others outside of what the Constitution guarantees for all of us. But I think it's I'm not sure we always recognize how important it is to be active and to pay attention. I've seen many women's health issues overcome, and I think my thing has been to show, like when I talk on women's health, and I get excoriated by many men, and there was a guy in the men's health movement, like, you know, you're just discriminating against men, you're not paid. So that's why my slide now says, and I got applause when I showed that in East, and then it came up, this assumes men are there anyway, we're just adding, to show that if you come out that you're opposed to what you're looking at as opposed to expanding, it makes a difference in many of these issues. And so being inclusive, but giving attention to where there are deficits, I guess that's the word. You want to look at increasing the science, increasing the knowledge, so that we can treat all people better or preserve health for all people is important. And I think that argument has worked not only in the U.S. but around the world. So anyway, I'm still talking and I'll be quiet, but thank you all very much. Thank you. I'd stand up for you, but I'm already standing. Thank you so much.